The Parkinson's Podcast is brought to you by the Davis Phinney Foundation and brings you the stories, wisdom, and expertise of people living with Parkinson's, care partners, and Parkinson's professionals. In this episode, John Dean, a speech-language pathologist who exclusively works with people with Parkinson's, talks about the impacts that deep brain stimulation can have on speech and swallowing.
Hi, John. Nice to talk to you again.
Good to talk with you today, Chris.
So we're going to talk about some questions about deep brain stimulation. And to start us off, I would just wonder if you can tell us a little bit about your background in Parkinson's.
Okay, well, I'm a speech-language pathologist or a speech therapist, and I specialize in working exclusively with people living with Parkinson's or something that looks like Parkinson's, one of the atypical diagnoses. I don't really do any work in any other areas, and I've been working in this field for about not quite 20 years. I think 2007 is when I started really focusing on Parkinson's. I built some networks of interdisciplinary teams like the Parkinson Net model. I was borrowing from them. I did some work in some tech startups. I worked with some nonprofits. But really, I focus now on exercise and dual task exercise, and we do that pretty much all online anymore these days. So that's most of my work is online.
Well, thanks for joining us today to do some online work with the Davis Phinney Foundation. I really appreciate you taking some time to help us understand the impacts of DBS on speech. So we're often asked about this topic. In particular, we're asked, what is the likelihood that deep brain stimulation will impact a person's speech and swallowing? I wonder if you can just start off by describing what DBS is and what do we know about how often DBS impacts speech and swallowing for people living with Parkinson's?
Okay, yeah, I mean, at a very high level, deep brain stimulation or DBS is something that's been around for 20-ish years. 2002, 2003 is when it started coming out. And you place leads into the brain, deep into the brain. So there are electrodes that go down there and they put electricity through them. They come into the head, the wires go down and it attaches to a battery, usually in the chest. And the idea is that the stimulation, it basically interrupts misfiring circuitry in the basal ganglia, so which are these structures involved in movement, in planning and patterning movement. By doing that, there's a situation with the lack of dopamine that circuit gets out of whack, and then some things that should be exciting things are not exciting them as much, and things should be inhibiting or not inhibiting properly. And the DBS somehow interrupts that, resets that circuit. And the real benefit of DBS is that it's always on, and it provides a lot of the same benefits say like a medication like Cinemat or something like that.
So DBS does have a positive impact for many people, but it can also have some side effects or some impacts that are maybe not what were intended. And some of those involve speech and swallowing. So how often does that happen that DBS may impact someone's speech and swallowing?
As an SLP, in the early days of DBS, there was often a very kind of Faustian bargain. The people that I was working with would definitely get some benefit in their mobility, and they would take much less meds. But there was quite frequently more issues with speech that we could address in treatment, but not always successfully. But there's also benefits to it as well, because just like if I take a medication and the movement related to my teeth and my lips and my tongue, the things I'm using to articulate, or even my breath support, those things are actually going to get better with medication, and they're also going to get better with DBS, the motor components of speech, of communication, of swallowing. And so those do improve. And you might even find some people who report having better communication after the DBS. But then if you want to make it more scientific, then I would go to somebody like a researcher that was at the University of Florida before returning to Japan named Suboi. 25% of people with Parkinson's in his study actually improved their function.
And is this improved function in terms of speech or improved function in terms of general mobility?
Speech. But again, it's the mechanics of speech. It's the articulatory speed. You know, like if I'm feeling off and my medications aren't working and I'm getting ready to make a T sound, now the T is supposed to come back against the alveolar ridge and it makes contact. But if it's not moving quickly enough and it's mistimed, now you're going to have a little frication noise in there. So those kind of factors are what we'd expect to improve with medication. Those are the factors we expect to improve with DBS. And so there could be some benefits, but then DBS has other issues associated with it because DBS has a stimulation device that's being placed pretty near to the structures that are going to eventually become the cranial nerves, depending on which DBS. And I think that's important to recognize that the first DBS that was approved was called STN in the subthalamic nucleus. And if you look where that is, it's right above the brainstem area. Then there's a high potential that electricity might bleed into descending corticobulbar fibers. That means from the brain to the brainstem, connecting them, and they become the cranial nerves. And that's what produces the movement of your lips and your teeth and part of your voice production. The DBS itself might be in a position where it could actually have current that's bleeding into these areas and causing problems. And that won't happen with medications per se.
We often hear that when someone has a positive impact from medication, that is an indication that those symptoms may improve with DBS. So I think what you're suggesting, and tell me if this is right, that if I had some speech impairment that's related to my motor control and Parkinson's, and that improves with my medication, does that mean that my speech impacts are more likely to be improved by the DBS treatment if I went through that procedure?
I mean, at a very high level, if you are someone that gets pretty good benefits from the medications, that's why when they do that testing for you when you go to get DBS, they're going to do that Unified Parkinson Disease Rating Scale, and they want at least 30 points. More is better. You have to show some benefit, right? And if some of the benefit you get is maybe better postural control, better breath support, better articulatory processes, maybe that would be something that could be improved by DBS, and you could come out with a better outcome for sure. I would say for speech, your ability to move your lips faster, maybe even be a little bit louder, definitely have better posture, so you're aiming your signal to people when you're using your eye contact and gestural things. But maybe the intelligibility isn't always improved, and that could be affected by a lot of factors. It's Parkinson's, right? Everything can happen all at once and change.
Everyone's experience is going to be a little different. So we want to make sure we say that and be clear about it, that nothing is going to determine with 100% accuracy how you as an individual might respond and what benefits or detriments you might have from any treatment. So I wonder if you can just say, if my DBS signal is trickling into having an unintended impact, what are those impacts possibly going to be?
Let's make it less definitive than this, because I think it's important to say that, again, back in the olden days, in the early days of DBS, there would be some more significant problems with speech, but those problems wouldn't be insurmountable, and they would be overshadowed by the reduction of medications if you did STN DBS, and it would be overshadowed by the improvements in mobility and the reduced fall risk, especially after the pre-programming of that. But I would say anybody with Parkinson's who comes into my clinic, DBS or no, when I'm listening for, the first thing I'm hearing is pretty quiet speech, right? I'm hearing less articulatory precision. I'm hearing some distortion of the vowels and stuff like that. Those are all coming in there, and that may be improved when they take medications or might not. Usually we do an LSVT or speak out kind of treatment to approach that. But the DBS, because it's always on and it always has current, I'm also hearing in people with Parkinson's who have undergone DBS a little bit of slurring sometimes. Sometimes the voice can be a little bit, I can get some spasticity into that voice that's not common. It's the hypophonia, the quiet voice, is usually kind of part of the hypokinetic dysarthria. So you can see some slightly different things, but again, it's not whether it's present or not. It's not whether I can sit there and pull out, the right software and say, right there's a problem. It's more about what is your communication capacity? What is your ability to day to day live the way you're supposed to and be able to communicate the way? And if there's a barrier, so let's have a conversation about that. And I could also say too that sometimes someone's own self-impression of how they're doing may not match my clinical impression. But if you and your coworkers and your care partner and the people you see and your family, it's all working pretty well, then I don't want to look for a problem that isn't there, right? Now, that having been said, if you're coming to your doctor and you're undergoing DBS assessment and you're going to do the testing, the neuropsych testing, which is quite intensive, I would say that it's just important to realize that the reason why you're probably doing the DBS is not to improve your communication. is probably to address the motor fluctuations and some of the mobility issues. And so now I want to say what may crop up with the DBS is probably addressable either with programming, with therapy, with some of the technologies like a speech vibe. There may be other ways around it. And there might even be situations where you have a programming that's optimized for movement when you're out and about and being mobile and you want to have the best movement ability, and maybe something that's optimized for communication. And so there's different options. And so I can say somebody that's got pretty serious speech issues or those speech issues are not likely to improve with the DBS. Somebody that had a childhood history of stuttering, disfluency, we say in clinical terms, that may crop up again at some point during the DBS. But again, it's probably, if it's not 100% fixable, it's addressable. And you're putting this kind of hierarchy. If I'm not able to be moving safely, if I'm having a high risk of falls, if I'm taking lots of meds and they're not providing you with relief, don't let a speech change that we can probably address or at least come around with other solutions for dissuade you from considering DBS.
Well, thanks for that, the context, because I think what I understand you to be saying is that big picture here, speech impacts from Parkinson's happen with or without DBS, and there are things one can do to address them with or without, whether they result or develop after DBS or before DBS. And so the primary considerations that one might be well served to consider before DBS are what are you trying, what is the outcome you're after? And if it's communication improvement, well, then maybe there's an approach you take to the DBS surgery and location choices, but probably most people aren't choosing DBS for that reason. They're probably thinking about DBS to deal with complicated medication issues and fluctuations and motor function.
There's a paradox here too, though, because probably the better DBS for speech, if you're somebody who is either like a professional voice user or you have to use your voice as a teacher in a context like that, or if you have the presence of some more prominent speech issues, or for me, I'd be more worried about swallowing. Obviously, communication's important, but swallowing is very critical. The GPI, the globus pallidus pars interno, would probably be a better choice. It's farther away from the structures that are really going to be infected by the DBS. But the other problem with the globus pallidus is that you don't end up reducing the medications at all, or if you do, very mildly, and it also is a much bigger target. It's like 10 times the size of an STN, so you're going to use a lot more current, which means you're either going to have a rechargeable battery or you're going to have to change the battery more frequently, which is, it's outpatient surgery, but it's still surgery. So there's a lot of factors there. But yeah, nobody's doing DBS for communication. People who have had more communication issues need to be a little more careful. But I would say then, hopefully you've had a relationship with a speech therapist and you've done the things you can do to improve your communication as much as possible. And then when you go to do DBS, then we have the target of what we're trying to get back to if there's been real changes there, and the bag of tools is bigger.
So let's talk about those tools a little bit. I think you mentioned something that I'm not familiar with a moment ago. You mentioned that there's some therapeutic interventions just in terms of exercise that you might do with me if I came into your clinic and we were talking about this. But you also said something, was it something Vibe?
The speech Vibe. Have you seen that device?
No, I haven't, but I'd love to hear about it. Tell me about it.
Well, it's an interesting device. It's been around for a while now, but they now have a Medicare billing code, which is a big deal in startup world, because if you can't bill for it, then you're asking people to pay for it. But basically, it's a wearable that you put in the ear when you talk. It has an accelerometer that's built in here that can see when your jaw's moving, and it knows you're talking. And when it does that, it puts loud noise into your ear, and that triggers something called the lumbar effect, which is a reflex. And a reflex means that you can't really fight it. It's not a reminder. It's not a cue to like, oh, you know, speak up or whatever. It's actually in your ear, and when you have loud noise in your ear, you automatically talk louder, like we're all at the ball game, right? And the cool thing that they did with Speech Vibe is that they used something called multi-speaker babble, and what that means is that they got a room full of people talking. And that got around a key problem. The lumbar effect has been around for a long time, but before they were using white noise, which is static, and The problem with that is that we tune it out after a while. If you've ever, somebody who's had a child, when you had your first baby, every time the baby cried, you're running up and going on there. After a while, you figure out like, well, that's an important cry, and this is not an important cry. And by the time you had your third baby, you've tuned it out entirely. I'm kidding. I don't have kids, so don't send all those complaint letters to Chris. But the idea is that we would have this neuroadaptation, and you would tune it out. With multi-speaker babble, you don't. And then there's something about the human mind that when you hear a bunch of people talking, you're listening like, I think they're talking about me. Did I hear someone say John there? Like, you can't get away from it. And that's a big solution. So they've taken a physiological effect, the lumbar effect, and they put it into a form factor that's very portable. It's not for everybody, but they published some interesting research showing that for people that have a hard time keeping their focus and their cognitive focus on being loud all the time, it's a nice tool for that. And it could be something I would use for somebody who failed in the traditional approaches of like LSVT, although LSVT did research on post-DBS treatment, and they got pretty good results. They got about what I get. About half the people got about better. I think it was 6 out of 11. And that's kind of what I would see. But that's only one part of it. You could have that Speech 5 tool. That might be one part of it. We could definitely do some training to make you louder. But then you could also have a situation where I could put in some augmentation to the vocal folds, and they would come a little closer together, and you become a little bit louder that way. That's another thing that people are doing. There's a lot of approaches. It's not one trick, and it's not always just making you louder. Another thing that happens with DBS is there is some increase, some problems with what we call verbal fluency. And verbal fluency is simply the ability to generate words on demand. And you have a semantic fluency, like category words, and you have a phonemic fluency, like words that begin with the letter K. And the category words are much more language related, and those seem to decrease a little bit after DBS. Although, to be clear, nothing else cognitively seems to be changing. And so sometimes when I'm helping someone improve after DBS, it's not all about making them louder. It's also working on the language-related components and helping them become more fluent rather than just being louder.
So that's important, I think, because you just drew attention to a couple of pieces of the work of a speech-language pathologist and the different ways that clinician, a speech-language pathologist, might be able to help someone living with Parkinson's. But one other thing that you've mentioned a couple of times that we haven't really talked about is swallowing. So what are the impacts of DBS on swallowing, and what are the cues to somebody that it might be time for them to seek help with regard to swallowing, and what help can be offered?
If I could start with my standard statement on swallowing, because it is such a big issue and it's so important, and it tends to affect quite a lot of people with Parkinson's, but their recognition of it is not nearly as high as it would be for, say, a speech issue. And this makes sense because voice, it's not visible, but it's audible, so it's perceivable, and you have a lot of reinforcement day in and day out. If you're going to the bank and people are leaning into you or saying, could you speak up? Okay, you're becoming aware of an issue, but if you're not swallowing properly and you're putting yourself at risk for problems that are related to food from your mouth getting into your airway, causing an aspiration event and possibly pneumonia, you might not see those clear signs. So what would you be looking for as a person living with Parkinson's who's maybe noticing some changes in your swallowing? Well, very early formation is problems with pills. So when you find yourself in a situation where if you take more than one pill, you can't seem to get it down very well, or you have to drink a lot of water. I actually don't like water with pills. I like taking it with some applesauce or something that gives it a little bit of bolus to go with it. Or if you took more than one pill at a time, it would be problematic, and you'd have one of them getting stuck in there. Those are all indications of swallowing problems. But I think another one that happens quite frequently is when you're swallowing liquids and a little of it goes down the wrong pipe. And this is where the trap is, because it goes down the wrong pipe for all of us. We all have water that goes down the wrong pipe. Okay, but if it goes down the wrong pipe whenever you're drinking water, or at every meal, or at least once a meal, okay, that's pretty frequent. That's much more regular than I would expect. And that would be a reason why you'd want to get a referral to an SLP to get an evaluation. Another one is drooling. They call it sialuria is what we say medically, and that means excess saliva. Rhea always means too much of. But actually, people with Parkinson's don't produce any more saliva than anyone else does. It's just not being managed as well. And the risk of that is if you have drooling that's happening, that means that it's not being managed up here. Well, it's probably also not being managed in the back parts where it can escape past your defenses. Normally you swallow the saliva so you don't have too much in your mouth. And that way you don't have parts of it going from your mouth into your airway where you can inhale it and aspirate it and cause problems.
So what about issues with eating and pushing food to the back of your mouth? Is that a challenge with it that it may be impacted for people, or that may affect people with Parkinson's?
For sure. Again, anything that you can see in Parkinson's, anything that happens visibly, so your movement is smaller, your handwriting is smaller, your facial expression is less than it used to be, or people notice that, well, that's going to happen anywhere that you can't see. So when you swallow, your tongue comes up and kind of makes a nice airtight seal and then uses pneumatic pressure and pushes that food into the pharynx, which shares the airway in the front and the food passes way in the back. And if that air pressure is not tight, maybe you have a leak. Well, you're not going to get full movement. If you have tongue that you're supposed to be moving the food from the front to the back, or you're supposed to be forming into a bolus so that you can get ready to swallow, and maybe some of the food's leaking even to the side of what we call the lateral sulcus between your cheek and your teeth. Those are all things that can happen. Those would be more prominent. You would probably notice that before you would notice a little bit of drooling when you wake up in the morning. And you would probably notice those things like you would notice the problem with pills. Pill dysphagia, as we say, is probably one of the earliest things, and almost everyone I know with Parkinson's has some issue with pills, especially if they're big.
And so this points back to one thing to keep in mind. You might hear that there's challenges with speech impacts to DBS, but this goes back to an earlier statement you said, which is that if you're having trouble swallowing pills, well, if you have DBS, you're probably, or one outcome may be that you lose or that you decrease the amount of pills you take, which could just on its own be a positive impact on swallowing function because you don't have to swallow as many pills. You have less chance of having an issue when you're doing that.
With the caveat that is primarily for subthalamic nucleus STN placement of the DBS. I believe with GPI, much less likely to reduce pills.
It sounds like your perspective here is that the real answer to the question, how do I navigate the decisions surrounding DBS and the risks or the cost-benefit analysis, is really to start from the foundation of having a good team on your side. And you need to communicate with them. I think what I'm hearing from you is that you would say, be sure to discuss the issues you're having and be clear with the people you're talking with on your care team about the issues you're having before you have DBS, so you can think carefully together with that team about the targets you might choose with your care team to where your stimulation will go. And it sounds like also you think having a speech language pathologist early as a part of that team and they can be involved in that discussion about DBS is an important thing to keep in mind. Does that sound like I summarized this?
Yeah. I think that it's important to, when you're having these early conversations, hopefully you are working with a team. Wherever you are, there are people who live in big metropolitan areas. They have all that embarrassment of riches. They can go to one team or another and they can shop around. But that's not the case for everybody. But I think that it still behooves you to have a relationship with a rehab team that knows what they're doing. And hopefully they're involved with the doctor. And then be confident in the fact that you let them know what your problems are. We address them as much as we can. And after you've undergone the procedure, that we are still keeping our eyes on where the problems are, but we should be able to address them. So I guess what I want to say is that there are things that can definitely happen. It definitely can cause some communication issues. I'd say as an SLP, I hear things frequently. I can hear people who have had DBS, but it's not interfering with daily quality of life, and it's not interfering with their ability to do what they need to do on a daily basis. And this is a part of it. It's like having perfect pitch. Like walking around with perfect pitch is not that great, actually, because many things are out of tune, even instruments. And so it's like, it's not a skill that you need. But I take it back and say, okay, well, take away my practice ear and say, I'm living with Parkinson's. How much benefit am I getting? What problems am I dealing with? is this one of them that needs to be addressed? Am I getting enough benefit from the device to overcome any concerns I have with the communication?
And the key to that is to recognize the challenges you might be having and articulate them to the people who are providing your care. And with that in mind, I think I have one more question, if you have another moment, but I'd like to ask, just how can people find a speech language pathologist? How do we get in touch with one, and where do we find you?
Yeah, and I mean, you said something really important right before then as part of that, is like you want to find these problems and you want to articulate them with a speech therapist. And I would just say that what I would say to anybody who's just got diagnosed with Parkinson's or anywhere on that spectrum, whether they had it for 5 years or 20, is you should have a relationship with a speech language pathologist, and they will also help you identify the issues. Because again, some of them are not going to be perceivable easily to you, or they might not seem like it's a big problem. Why? Yeah, I clear my throat when I'm swallowing sometimes, but it's not that big a deal. Well, we can help you identify whether it is a deal that's worth addressing, or as you surmise, it's not. As far as finding an SLP, you can go find, you can look up on the ASHA, American Speech Language Hearing Association, on their website. I actually like to go to registries where people have had some certifications, and probably the one that I would point to would be probably LSVT and Speak Out. And those are two different approaches. They're for communication, they're not for swallowing. There's no swallowing approach out there, but and I would find people who have been certified in those basic introductory kind of approaches, because they have at least some experience working with Parkinson's. And then if you find someone who's certified in both of them, that's probably a good sign. That means that's a nerd. And if you have somebody that also is a part of the International Parkinson and Movement Disorder Society, as I've been for about 15 years, that tells you that that's someone who's focused on there. I think another good resource that you could consider is just when you go to your support group, finding other people who've had good experiences, because people who work with neurological illnesses tend to work in that space, and people who work exclusively with Parkinson's or a lot in Parkinson's, you're probably going to find your community through your support group as much as anything.
All right, John. Well, thanks for taking some time to talk with me about this subject, and I appreciate your insights. I just wonder if there's anything else you think I didn't ask that I should have asked, or anything you haven't said that you want to say.
I find that sometimes after the procedures happened, that I have a harder time kind of calibrating people to what's the level of effort. And it's because there's something that's providing a constant source of stimulation over time. And so if it's possible, I like to do a little bit of prehab and get people as strong as possible, because then I know kind of what's doable, how well their voice is going to be improved. And then after DBS, I have the target that I'm looking for, and I can also say, well, this sounds a lot different. It doesn't sound a lot different. It's just one of these things where if you're going to do DBS, it wouldn't be the worst thing in the world. If you've done LSVT in the past, just go in for a touch-up and get it back in shape as much as possible, just so we understand, like, this is as good as it is in November of 2024, and I'm doing DBS in January, so that when we start doing our work after that, we have a nice, easy target that I can look at. Not, oh, I remember when so-and-so came in 8 years ago. Well, it's Parkinson's. It's changed. We want to make sure we capture the real thing. It's a different approach to treatment after DBS. It's not worse. It's not better. Well, it's something that a good clinician can get around. This is why you want someone who knows a thing or two about Parkinson's, been around, because we're going to have a bag of tricks, and I'm not going to have a one-size-fits-all solution. But give me the bellwether by being able to see you before you go in. Everyone living with Parkinson's disease should have a long-term relationship with a speech-language pathologist and a physical therapist and an occupational therapist. And if you're really lucky, you'll have a nurse that you can work with, and a social worker, and a neuropsychiatrist or neuropsychologist.
All right, John. Well, thanks for taking some time with me. I really appreciate it, and I look forward to talking with you again sometime soon.
Yeah, good catching up with you, Chris.
Thank you for joining us for this episode of the Parkinson's Podcast. For more information about the Davis Phinney Foundation, and to learn about educational offerings and community events for people affected by Parkinson's, please visit davisphinneyfoundation.org or dpf.org. This content includes information, insights, and opinions from our Parkinson's community. The views expressed are those of individual participants and do not constitute medical advice. This content is not intended to substitute for the guidance, advice, or recommendations of your personal healthcare providers.